Hi, everyone. We're going to go ahead and get started. It's 1 o'clock. Welcome to STD, Did You Forget Me? A webinar to bring us all up to date in terms of statistics, diagnostics, and treatment options for STDs in this unprecedented time of COVID-19. It's great to see everyone here, even virtually. I know a lot of programs and staff have attended this annual webinar in the past, so welcome back. And for a bunch of our first timers like New Hampshire Department of Corrections, welcome. We're happy to have you. We originally were going to have camera sharing, but it looks like you might be only able to see us. Today's webinar is going to be recorded, so if you know some colleagues that might not have been able to join the live presentation, it's going to be available on our website afterwards. My name is Chrissy Nikitas. I am the Syringe Services Program and Viral Hepatitis Coordinator. Along with me on the planning committee were Laurelette Moyer, the Infectious Disease Prevention Services Manager, Megan Danubila, Provider Relations Manager, and Janice Carlson, Education and Training Coordinator. And we're all here from New Hampshire's Bureau of Infectious Disease. We have a great presentation for you today. We're really excited. Just to briefly outline the agenda on what we'll be touching on today. First, we have an overview of STD statistics and surveillance with Elizabeth Bone, our statistical assistant with the New Hampshire Bureau of Infectious Disease. From there, we'll go to Ann Goldborn, our sexual health nurse specialist, who also works with us here at the New Hampshire Bureau of Infectious Disease. She's going to be covering some stats on congenital syphilis and expedited partner therapy. From there, we're going to talk to Dr. Catherine Hsu, the medical director for the Division of STD Prevention and HIV/AIDS Surveillance for the Massachusetts Department of Health and the director of the Rattel STD HIV Prevention Training Center. And we'll wrap today with Ellie Doig, nurse practitioner from Planned Parenthood of New England, on updates and tips for taking a thorough and accurate sexual history. So a couple of ground rules. We're going to stop between each section for questions. So if you have questions, if you could please type them into the chat box because everyone will be muted so we're not talking all over each other. I'll read it to the subject matter experts and we'll go from there. If your presenter has already moved on and you think of something after the fact, there will also be some time at the end for questions and we'll go back to our panel of presenters. If you're not comfortable with asking your question on this forum, we'll also be providing all the slides and contact information after the webinar today. So that all said, we are going to get started and we have Elizabeth Bone. I'll hand it over to you.
Bear with me. It keeps asking me advanced sharing options. I didn't have this on Wednesday.
Try clicking on that.
Okay.
Okay, I had changed this earlier, but now you should be able to.
Okay.
I had set this at the beginning. Okay.
All right. Thank you.
Go.
Hi, everybody. I'm Elizabeth Bone. I'm just going to keep it short and sweet with our surveillance updates today. So starting with numbers, it's no surprise or secret that STIs have been on the rise in New Hampshire. If you would like more information about the nitty-gritty, you can go ahead and check out our 5-year report on our DHHS statistics page. As some general updates, we've been onboarding more facilities into our electronic lab reporting system. It keeps our results closer to real time, and also it's more centralized in one place. We've been doing a lot of QA to track multi-site specimen source testing on electronic labs. We were noticing previously that some information was being left off, so we've been working hard to include that in our electronic lab reporting to help us get a bigger picture of STIs in New Hampshire. Oh, sorry. And then we also have some emerging data It's still new, still kind of small, but we are noticing an increase in web-based care or at-home testing services being utilized. So I've been in this position 2.5 years, and we noticed New Hampshire residents in all kinds of states, but turned out they hadn't left the state at all. They were just testing at home and using these companies, which also use LabCorp and Quest, so that's how we were able to get the result. Another thing we've learned is that patients may still follow up with a provider in state, or they may choose to reach out for treatment through the testing service. Okay, so everything relates back to COVID right now. I'm not going into the weeds, but just that the number of COVID infections has surpassed that of chlamydia, which was previously the most reported infectious disease in our state. So at present, we're well over 5,000 cases for COVID in New Hampshire, whereas even in our record year for chlamydia, we've only had 4,006. And you also want to keep in mind the time frame here, because we've had a few months versus 4,000 in 12 months, a whole year. So that's why we're busy. So for some more observations we've observed, providers are treating patients empirically to reduce office visits and help prevent the spread of COVID. Colleges and universities, of course, have been closed. And schools aren't reporting, but that's not to say the people in that demographic, that age group, they still continue to test positive. Lastly, we have different factors that contribute in the trends in STI incidents and reporting. However, we continue to receive case reports and lab results, even when there are major social distancing measures put into place. So in other words, people aren't completely isolating, and we still have the data to show that. So thank you.
All right, perfect. Thank you so much, Elizabeth. Let me just check if there are any questions in the question and answer box for Elizabeth. Also, there were a couple of questions that I typed in the answer to for people who came in late. Yes, the slides will be emailed, excuse me, after the fact today. So not seeing any questions. I don't think I saw any in the chat either. We will move on to Anne. And so, Anne, we have you talking about congenital syphilis and EPT today. So the floor is yours.
Hi, sorry about that. So let me just make this, there we go. So my name is Anne, and I'm the sexual health nurse specialist for New Hampshire. And I just want to say a few quick things about some of my favorite topics: congenital syphilis, EPT, and I'm going to throw in a little bit for extragenital testing as well. So the CDC has started releasing some new surveillance for 2018 numbers, and those do show that cases are still increasing for congenital. Most of the cases are in the South and the West, and it is lack of timely care and adequate treatment that has been predominantly the missed opportunity. The emphasis is going to be on retesting and treating later in pregnancy. Oh, I'm sorry, Megan. Go ahead one slide. Thank you. Okay. I don't know why mine's not going, but next slide, please. Okay. So missed opportunities. As I said, a lot of the information that's coming out now is that there are gaps in testing and treatment, including prenatal care. All of these are preventable. About 1 in 2 newborn syphilis cases occur because of either gaps in testing or treatment that could have been completed during prenatal care. And the smallest percentage is late identification of seroconversion, perhaps in the second or third trimester, but it does happen, and it has happened in a few of the New Hampshire cases as well. Next slide. In terms of New Hampshire itself, we have had one case in 2018 and 2 cases in 2019. Probably one of the cases in 2019 was a real study in a missed opportunity. It was entirely preventable. A mother was checked for herpes twice in the second and third trimesters. Both times it was negative. They were considering performing a vaginal biopsy and never retested the RPR, and none of that was reported until after the birth. We haven't had any, touch wood, any cases in 2020. We've had several women who are pregnant and have been appropriately treated, but there's still room for improvement, as some hospitals are still not either testing when the mother and baby deliver to check the RPR, or they are not reporting the results of the birth to public health, so we can make sure that everything proceeds as it should. Next slide, please. In terms of sexual health challenges that we're facing, schools went online back in March. Do we know how that's affecting sexual health education? We have had to try to refer people to places like Planned Parenthood and other clinics, because the Manchester and Nashua health departments have closed their STD clinics because they have been overwhelmed with COVID response. But on the positive side, we have continued to complete all of the STD investigations that have come up uninterrupted during COVID. And while ambulatory care offices have been closed or have had limited availability, we have still been able to update our EPT materials and try to focus ahead on a partnership with pharmacists so that we can better equip them to help us with providers who prescribe EPT. Now, next slide. What is EPT? I'm sure most of you are at least a bit familiar. It is now legal or permissible in almost every state. And next slide. We have 2 options. One is that people are provided antibiotics at the time of their visit to then give to their partners, or people are given a prescription to then give to their partners. This is intended for heterosexual sex partners that a person has had within the last 60 days, and this is only for chlamydia and gonorrhea. What we want to do here is secondary prevention, decrease any reinfection with people getting reinfected from their partners, and increase the number of partners who can get treatment if perhaps they are less likely to go to a provider themselves. Ideally, every partner should get the first-line treatment, which at the moment is ceftriaxone and azithromycin together. But at least EPT gives us another way to help some of the people who may not be able to make it to a clinic. And next, it's a harm reduction strategy that is used to try to help partners who wouldn't get into a clinic or perhaps don't have insurance. It has been studied and continues to have some peer-reviewed studies being done. It is not recommended for syphilis. Syphilis is complicated even with an in-person visit. But with syphilis, one needs to determine their staging which can determine appropriate treatment. Possible complications need to be ruled out, neurologic, ocular, and if a person is pregnant, they should definitely be seen in the office. Plus, with syphilis, you need lab results in order to confirm the diagnosis and for follow-up to make sure there is a response to treatment. So for patients not eligible for EPT, on the next slide, that would be men who have sex with men. They often have a high risk for coexisting infections like HIV and syphilis, and they should be evaluated. Pregnant partners, as I said, they have a greater picture to consider. Any pharyngeal gonorrhea infections, the suffixeme is not as effective in those cases, and a test of cure ideally would be done. And then anyone who has any known allergies. Next slide. Yep, the EPT treatment for gonorrhea. Now this has changed from the interim STD treatment guidelines, which I reference here in the references, and which was put out, I believe, in April. They have increased the suffixeme dose to 800 milligrams, still used in conjunction with a gram of azithromycin. And there are some alternatives that are there listed. Doxycycline can be used if azithromycin is not available. There have been shortages of azithromycin in different places, so certainly doxy can be used as a second choice. And then for some frequently asked questions that I have heard from providers in the next slide, do you need to put the person's name? Is it legal without a name? No, you don't have to put the name there, but as we are learning, it is more likely to be accepted by a pharmacist if it has a name. Do I need to include educational materials? Absolutely. The partner should be given information on STDs, how to take their medication, what their medication is. And I've put a link here to the EPT section on the DHHS website that has just recently been updated and will continue to update. So materials to give partners can be found there. And yes, it can be given to minors as well and remain confidential, but also consider possible barriers to them utilizing, particularly a prescription. So on the next slide, I just briefly outlined one of the studies that was talking about optimizing EPT. What's the best way to do it? So most of the studies initially, when this was studied by the CDC, were for partner-delivered patient therapy, which is giving medication to your index patient and then they give it to their partner. But in the real world, as we know, that's not often acceptable, or it's not allowed in the practice. So most of our index patients are given prescriptions. So there are some identified barriers to that. There's more steps involved. You have to travel to the pharmacy. The partner may now have to pay for it. If this is a minor, an adolescent, then are they going to want to use their parents' insurance for this? Will they have the money to pay out of pocket? You know, it's in a public setting, you know, at the pharmacy. Are they going to feel comfortable enough to ask questions? And we have had pharmacists who refuse to fill them either because they're not aware of EPT, or they think that, you know, perhaps there has to be a name on there. And electronic prescribing. I know that when I go to the provider, everything's on the computer now. So some of these programs don't allow you to write a prescription with no name, or it has to be sent directly to the pharmacy and you don't know where that person's going to go. So there could be many barriers with the prescription way, and hopefully in trying to work with some pharmacists here in New Hampshire, we're going to be addressing some of those. So there are other studies that have been done for implementation in the next slide. And that emphasizes that medication is probably the best way to utilize EPT if possible. There was a study that looked at giving out vouchers at different venues, and the Student Health Center seemed to be the place that had the highest success rate. And they also had an on-site pharmacy, and the pharmacist collaborated with the clinic, and they were aware, so there was mutual education and cooperation there. It got rid of some of those barriers like cost to travel and possible rejection of the prescription. So some of the things that we can look at are how can we distribute this medication to more offices and more places, and working closely with our pharmacists. So then I just have a couple of quickie slides on extragenital testing, one of my favorites. You got to do more than look. So don't forget the extragenital, MSM, transgender women, people living with HIV, and anyone who reports receptive anal or oral sex. For MSM, you want to do it at least annually or every 3 to 6 months, as risk behaviors may indicate. Urine-only screening may miss up to 90% of rectal gonorrhea and almost 80% of rectal chlamydia in MSM populations. So it's also an opportunity to discuss PrEP, which is also something that providers ideally should be utilizing more. Next slide. This is predominantly showing in the MSM population, over 70% across the board of pharyngeal and rectal gonorrhea and rectal chlamydia is missed just by doing a urine test. So very important to check all sites. And then the last slide. This is a study that looked at men who have sex with women and women who have sex with men, finding that they have an unknown disease burden. Certainly 3% of pharyngeal GC in men who have sex with women would have been missed if it was urine only. And in women who have sex with men, they actually had a higher rate, 3.8% for pharyngeal GC, and also rectal GC and rectal chlamydia, almost 12%. So all of those would be missed if, A, we don't ask, and B, we don't test. So all very important, and certainly I'm happy to talk to providers who call me and ask, who should I test? And I say, everyone, ask the questions. So make sure that you are open and honest with your patients and that you know what types of sex that they're having. There's a reference page, and then the last slide also has further contact info for myself, Rachel Cush, who is our infectious disease care coordinator, and Elizabeth Bone for our STD statistical assistant as well. And I thank you very much.
Fantastic. Thank you so much, Anne. So don't go on mute just yet because I have a list of things here. First of all, Ashley says, Anne, we love you at Exeter Planned Parenthood office. You are a rock star angel, literally the best of the best. Also, don't forget indie clinics like Joan G. Lovering for STD testing referrals. They have sliding scale and free care. So we have a couple of questions. First from Gabrielle, why is EPT limited to heterosexual partners?
Largely because men who have sex with men have a higher risk for co-infection. So the benefit of treating a gonorrhea or chlamydia infection would not be as great as if you discovered an undiagnosed HIV diagnosis or syphilis. So men who have sex with men should be evaluated in an office. type situation.
Perfect. Lisa asks, for MSM, any chance there might soon be more flexibility using a harm reduction model?
I have heard that there are some places that are looking at that. Certainly, I think if you have very limited options, that sometimes those will be used. I don't know that it would be something that is across the board. It may be something that is particular to a certain area or certain population that you want to make sure that you reach. So certainly, when it's a last resort, it is always ideal to be treated as well as to be tested, but certainly there is some wiggle room, and I know that there have been places that have tried both, just because either they have a very high incidence rate or prevalence, and they're looking for some other types of measures to use besides trying to get everybody in the office, but that would be the ideal situation.
So Ellie asks, EPT for trick.
That one, I'm going to defer to Dr. Shu. I don't see a lot of that because it's not reportable. I'm primarily just working with the reportable STDs. I'm not actually in a clinic. So that one I would defer.
And then Dr. Chu, did you want to go ahead and touch on that now, or?
Yeah, because I think that was the last one, right?
I have one more for Anne afterwards, but go ahead.
I was just going to say the same studies that studied gonorrhea and chlamydia EPT also studied trick EPT. The impact wasn't as great in terms of the effectiveness. No one really knows why that is. In point of fact, the impact is never as great for chlamydia as it is for gonorrhea. And we all begin to guess at the fact that even though EPT may get at the partners that the person has immediately had in the past few months, which is usually what providers do. They target the ones in the past few months. It doesn't get all the future partners. And in some areas of the nation, well, everywhere, chlamydia is incredibly prevalent. So you can't get all the future partners with expedited partner therapy if you're only looking backwards. And for trick, in some areas, it's very high prevalence, and it may have been very difficult to prove impact from treating prior partners. Be that as it may, I want to be clear that when you look at the guidance, any implementation guidance or any regulation doesn't say that you can't do EPT in MSM, right, Anne? Like, it's not explicitly illegal to do it.
No.
You could always, as a provider, many of us have bent the rules and just simply documented within the electronic medical record, hey, this person says they're in an abusive relationship, their partner will not come in, and the only, better is not the enemy of best. Let us go ahead and provide some form of therapy so that my patient does not become repeatedly reinfected. Like, you can document all your thoughts when you choose to bend the rules and maybe potentially even treat MSM or use EPT for trick.
All right. Lots of good questions. Anne, I have one more for you.
Okay.
And this is from Lisa. Is there specific testing for rectal HPV, either men or women?
That, again, I know that they also do almost like a rectal pap for men. And I know that, regular pap smears should be picking up HPV in the reproductive organs, but in terms of rectal, I don't know that I've heard of a lot of tests that have been FDA approved for rectal testing in women. Certainly for men, I know that they do it, but in terms of how often, I don't know if it's yearly. Again, I think Dr. Shu would probably be a better person to answer that one.
As I recall, I think you're right. And the issue is that there's no universal recommendation for screening, mostly because we don't know what to do with the
results, right?
And if you screen and you find it and you don't have a great colorectal surgeon who's not an overdoer, you're in grave danger of potentially removing a very vital, important bodily part without knowing whether or not excising the squamocolumnar junction where there's the HPV infection at the anus either results in reduction in cancer or doesn't harm the patient excessively. So that study is ongoing. It's called the Anchor study. Many sites around the nation, and a few in New England as well, although I don't think in New Hampshire, are actually examining whether or not best practices include annualized screening. So to date, just to be conservative, the patient population that you should focus your anal HPV and anal cancer concerns, the one acceptable population has really been the HIV positive individuals, even ones who are well controlled on antiretroviral therapy. Some of us do consider, if you do have a capable colorectal surgeon to refer to afterwards, that patient population may get more routine screening and follow-up because the concern for progression to cancer is far greater in a partly immunosuppressed population. So that's how we've been slicing and dicing the lack of data and thinking about the risks and benefits of being venturesome in this area. Was that the last question, Chris?
I think that is the last question for Anne's section. So Dr. Shu, thank you so much, Anne. Dr. Shu, you are up next. Go ahead.
Can you guys see my screen okay? Yes? Okay,
Yes,
great.
we're good.
All right, top SDI updates, pandemic considerations and beyond. And I think we're at 1:32. I will shoot to keep a little under 15 minutes, which means that I'm gonna rip through this slide deck. No, just kidding, you'll be able to keep up. All right, couple thoughts as we are in the middle of COVID. It's just unavoidable. It's in the news, it's everywhere. It's prevalent in our own thinking on a daily basis. Although we would all love to pretend that this whole thing is just a terrible dream and it's not really happening. It is. I have a couple thoughts on the fact that, pandemics actually incentivize a lot of creativity, and we've seen medicine have some terrific advances. And I think one of the major ones is incredibly obvious. So many of us on the front lines when we practice our clinical care are like, do we really need to see the patient in front of us to be able to bill for that? It seems so silly, but what we just did was expert, and we should be able to do a number of things that maybe don't require an in-person visit. And indeed, during the COVID era, I would argue that triage has upscaled and improved tremendously. And we have had to make and justify to ourselves, which means that we're better at doing it with our patients, who really needs to be seen. Even as we reopen and consider the strategies that are safest for reduction in transmission related to COVID, as we reopen, we can consider half this, half that kind of strategies, meaning, you could just maximize the telehealth and then reduce the in-person time to a face-to-face blood work, or the vaccine visit can be ultimately very shortened if you do a majority of the visit through telehealth. We can also start to think more about strategies related to self-swabbing. I'll touch upon that in the next slide and come back to it because it's particularly relevant to STIs. And in general, I think we've had some opportunities with CDC telling us explicitly, well, if the patient really refuses to come in and you're pretty certain about the diagnosis or that you can cover it with oral antibiotics, here are some additional oral options. So I'm going to talk through those too, because I know although some of you on the call may have heard about them, I know that I haven't had a chance to reach the DOC population in New Hampshire and the county health department clinics. I didn't get a chance to talk to directly about this too. So we'll review that. And thinking through who really deserves inpatient care has required us to think about who in which type of patient, symptomatic patient, Does an exam really change my differential diagnosis? Or lab testing that day in person in the office, could it change what I choose as my presumptive therapy before I even get lab tests back? And all of that gets filtered through what's the harm in a trial of presumptive therapy versus benefits of presumptive therapy. So what I mean is, if you sort of set out vaginal discharge, we've traditionally always realized that despite all what our patients believe, that it's all yeast infections or that it's whatever they had before, they're somewhat accurate about the fact that it often is what they had before. They are not at all accurate at guessing that it's yeast, considering that BV is actually slightly more common than yeast. So we always knew that it was better to do a little bit of testing, whether it was with an actual wet mount performed with a microscopist in your clinic, if you still had people who were skilled enough to do that, or if it was sending off a quickie test that either uses PCR to detect some of the higher levels of organisms that are associated with BV, or other tests, the rapid tests, which aren't really rapid because most of us still send it out and you still have to wait at least a few hours unless you're lucky enough like me to practice in a hospital. So in those patients, what's the harm though, if you couldn't make the diagnosis 100% and you trialed them on an antifungal or BV type therapy, depending on what their symptoms were related to over a telehealth visit, versus a proctitis patient, where I would argue that is the last thing we're going to let go of. That is the one patient where you probably do really want to see them in person to see if the lesions or the concerns are not just that they have pain on defecation or that there's a little bit of pus on wiping, but also that the lesion that you spy on a rectal exam might be more compatible with an ulcerative lesion, either leading you to believe that's co-infection with syphilis, or it's all syphilis, or it's syphilis plus, or herpes plus, or LGB. The hint that there's an ulcerative process might hint towards, if you get that chlamydia test positive, it's not just a routine chlamydia strain, it's an LGB strain. So you would want to change your therapy to like go longer. I would argue that proctitis is probably one of the last syndromes that we're letting go of. If somebody reports it, that's one where we might still encourage an in-person visit, but weigh it against that individual patient's concerns about their fears about coming in during COVID, et cetera. Okay, so what was I talking about with self-collected STI testing? It's self-collected STI testing. In fact, many of the planning sites have long since gone to this, having some realization that some of the studies that have been done in this arena have actually indicated that a patient self-sampling is actually potentially a few percentage points more sensitive than having the clinician sample. And I always dream or think that one of the reasons that could have been behind this was totally because the woman collecting the sample on herself is potentially spending quality time with her vagina and twirling the swab in there faithfully for a good 10 to 15 seconds or even more. Whereas clinicians, we're taught from clinician infancy not to keep the patient in stirrups for too long, so on and so forth. And we're like in, out with the swab. And it turns out really 10 to 15 seconds contact time is still required even for those super sensitive nucleic acid amplification tests that all of us use to make the diagnosis nowadays. This has now been shown not only to be equally as sensitive, but it's certainly, no surprise to all of you who are clinicians, probably more acceptable to our patients to self-collect, especially MSM, who at any ordinary day may not have been prepared to have an exam if they were completely asymptomatic. The preference might very well be to self-collect a rectal swab or even an oropharyngeal swab. And sufficient studies have been done at this point in STD clinic populations. I would advise that it was mostly done in those populations to sort of give us some degree of confidence that with the right descriptors and the right guidance, people can collect their own swabs quite well and detect any ongoing infection that needs treatment to prevent transmission. The caution I would throw into this is, even though some of the assay platforms are perfectly fine for this, they're certainly now FDA approved for extragenital FDA testing. The caution I have for this is that some labs have not yet, quote unquote, validated the assay for self-collection, which only means that they didn't do a sequence of tests where they compared ones that were clinician collected directly to self-collected, and they felt incumbent upon themselves to give you this caveat that you should not really be sending them self-collected swabs. So have a conversation with your local lab that you tend to use to see what their interest level is, shall I say, in receiving self-collected samples, and whether or not they'd really prefer not to because they haven't validated this assay before you just dive into the realm of self-collection, which I'm really excited about, but I don't want you to get in trouble with your labs. But to help you and to help our patients move forward, there are any number of schematics. And this is one, remember, our training center covers all of New England, but there are 8 training centers that are funded by CDC to keep clinicians up to date on the area of STD diagnosis and management and treatment. And this comes from our sister prevention training center, STD Prevention Training Center for Clinicians, at UW, all the way on the West Coast. And they have a bunch of test yourself posters that have a link that you can actually request from Amy Radford, who's become a good friend and colleague over the years. She's their director of their training center, and you can get Spanish and English translated directions for rectal swabbing, pharyngeal swabbing, and vaginal swabbing at least. And I think other STD clinics, like the one in San Francisco City Clinic, have it potentially translated even into more languages, but at least you've got English and Spanish handy. All right, touching upon the regimens that are now acceptable for pandemics and a situation where you may not get as many in-person visits that you used to think that you would get. There's a lot more flexible guidance from CDC, and the priority populations are, of course, those with STD symptoms, those reporting contact, and those at risk for more complications. The woman with vaginal discharge and abdominal pain still makes me incredibly nervous. I'm not sure I would be doing a pure telehealth visit. You got to remember that in my clinical time, though, I'm mostly working with adolescents and young adults who are not perfect reporters of their history. And to miss a case of PID would just be so dreadful to me that I would have a very low threshold for trying to bring that patient in, at least for an exam, so I could lay hands on that pelvis and try to understand with that patient, does that patient actually deserve 14 days of antibiotics rather than just a single dose for presumptive management? Pregnant women with syphilis, I think there are very few alternatives. In fact, there are no proven alternatives to anything other than bicillin. And so those patients will do need to come in. And any patients where you're seeing a situation where you're very suspicious it could be secondary syphilis, and they're reporting, say on a telehealth visit, that they have eye pain or that they have blurriness with their vision, very concerning for the rare patient that may have ocular involvement right during secondary syphilis. You don't want to miss that patient because that is essentially more of an ocular semi-emergency to emergency. And those patients still really do need to be seen by an ophthalmologist or yourself to get a sense of whether or not they actually have uveitis or retinitis and may actually need IV therapy. That would really change your need to bring them in. Routine visits are still being deferred, although as we reopen, we're pulling people back more. And all these strategies can help suss out who really needs to be prioritized. And I think the one thing I want to emphasize is all of the alternative therapies are laid out in a table that I think you can Google the CDC Division of STD Prevention Dear Colleague letter that was issued by Drs. Laura Bachman, Gail Bolin, and Kim Workowski. It was issued on April 6th to provide some therapeutic options to consider for symptomatic patients and their partners when in-person clinical evaluation just isn't feasible in the era of COVID. And I want to point out for things like male urethritis, not proctitis, where I told you I still kind of really want to see them on exam. Medullary what one of your approaches now is actually suffixing 800 milligrams. And I want to emphasize this dosing was never previously published. 800 milligrams, somewhat astonished most of us in the field, because we were like, is the person just going to throw it up after eating it? No. So the answer is that it turned out Lindley Barbie and Hunter Hansfield and a few other people had actually already looked at this in smaller case series, and it was tolerated. And for right now, we're going to keep it with a companion drug to cover, certainly for urethritis, where you're not sure if it's gonorrhea or chlamydia, you're going to use a chlamydia coverage regimen, as well as getting dual therapy in for your gonococcus, if that's what's there, with an azithromycin or a doxycycline kind of picture. Yeah, so that's one thing to keep in mind. And there's a whole list, and I'm going to have to refer you all to this chart in the interest of time from this Dear Colleague letter. Not only the interest of time, I know this is like microscript and all of you are just peering at your screen right now. And of course you'll get these slides later, but what you'll really want to do is download the Dear Colleague letter that has this table full blown. The key though, as we reopen, is that any patient who maybe got one of these alternative oral regimens really needs to be followed up closely. If they didn't improve or resolve within 5 to 7 days, and I'm not even sure I would give it 5 days. I mean, urethritis really should go the way of the dinosaurs. If you gave them a good oral therapy, they picked up the medication, it should not be lasting 7 days later, 5 days later. There should be some surcease to their symptoms. So they should come in if it looks like there's non-response that's potentially going on, because we are very concerned that multi-drug resistant gonorrhea can arise, especially with these treatment regimens, which may be less perfect for oral pharyngeal gonorrhea, which is where we think is going to be the first sign of drug-resistant gonorrhea. Patients should also be counseled to be tested for STIs. I mean, if you're doing great presumptive therapy, that's great, but clearly they had a drip or a concern or a pain. At some point, they should get tested just to document what it is that they had. And any patient receiving anything other than benzathine penicillin, the non-pregnant patients who have that option of doxycycline, should have repeat serologic testing performed 3 months post-treatment. The last few slides, I just want to cover that pandemics really do hide endemic disease, and that's the bad side to all of this. Here I had to default to Massachusetts data. I just didn't have time to pull all the New Hampshire information. I'm so sorry. But look at what happened in what we call the Morbidity and Mortality Weekly Report week, 12 to 13, which is basically the end of March. The last couple of weeks in March, there was a just dramatic boom, drop in chlamydia infections that were reported in Massachusetts. And we rely on electronic laboratory reporting streams. And we know that the laboratory reporting streams weren't dying out. It was more that the patients weren't coming in for routine screening, which is how the vast majority of chlamydia infection is picked up. But look, there was also an effect on gonorrhea, and I guarantee it, if I were to magnify the y-axis here, you'd see it better, and an effect on syphilis too, on our weekly case counts. So we all know, just like Anne and Liz pointed, Ellie pointed out, Liz pointed out, that we have seen some tremendous increases, and we're like back to 80s levels of STIs, which is kind of crazy for those of you who actually worked during that era. You're probably living in astonishment. And this is entirely diverged from our HIV curves. HIV seems to be a little bit more preventable, especially with HIV pre-exposure prophylaxis. And yeah, we know that decreases in syphilis were due both to behavior change and to deaths. And it's a great news kind of thing that people aren't so scared of having sex and maybe going barrier-free. But the problem is barrier-free sex will mean inevitably more STIs. So we are seeing that. With the baseline increase, we are seeing more complications. And our question is it actually true that it's likely even more complications? Because if somebody suppressed their desire to come in to see you and didn't even really tell you that they had symptoms, is it possible that sitting on their gonococcal urethritis gives it an opportunity to evolve into a gonococcal penile abscess? Yes, it is. Delays in treatment can, in fact, result potentially in more complications. So be on the lookout for that. The other thing I think that's been of tremendous concern is definitely that We've hidden other things because in the COVID pipeline of mass release of information that public health departments need to get out, we're missing the lead on congenital syphilis. And I'm sorry to say that we haven't been able to get our congenital syphilis stillbirth alert out. Even though we've had very similar stories to what Anne was telling you about in New Hampshire. And we do believe reinstitution of third trimester screening may make a difference in some of these cases and prevent them, just like Anne hinted at in her slides. We would love to do that universally for those women who do enter into prenatal care. We haven't been able to do that because the alert has been not gotten through clearance. There's just been too much COVID information. So let's see what happens. We'll all be seeing it together. We'll be witnessing what happens. Will we have missed more cases of PID or other syndromes? Will there be a surge of cases from a backlog? We don't know. We'll be witnessing it together. We're living these times together. The last thing I'll leave you with is this concept that the STD treatment guidelines, lovely though they are, have been static, supposedly, since 2015. And guess what? They're not going to be static. They're going into the 2020 version. Look out for major changes to gonococcal treatment regimens, even beyond what you're already hearing about today for oral treatment regimens. And really the best way to find out as soon as everybody else finds out and it's real time is download that app, a government app. Yeah, it's not half bad. It's still the best way to look up herpes, recurrent herpes drug treatment regimens. And it is free. Don't accept any competitors. Just go into the App Store or Google Play to find it. And of course, even though you can't stick Anne in your back pocket for advice or myself, you can always send us an email at stdccn.org, which gets you your closest training center faculty member on call for questions that you may have. We do answer them on a time point request that you request, 1 to 5 days. Give us as much time as you can. But if it's relatively urgent, just say 1 day and we'll try to get back to you. I got to unshare. I don't know how to do that. Oh, here we go.
Thank you so much, Dr. Shu. I'm looking in the chat in question and answer, although some of that may need some time to sink in. Let's see here. I don't think I see anything in the chat, but if you guys all think of questions, we're going to also go back to questions at the end.
Yeah.
Thank you so much, Dr. Shu. So last but certainly not least, we have Ellie from Planned Parenthood, and she's going to be covering taking a sexual history. Go ahead, Ellie.
All right, I was having some audio issues. Can y'all hear me? Great. Okay, so I'm going to do my screen share now. 1 moment. Okay, view, present. Great. Can you see my slides? Okay, and I'm going to try the thing we tried on our run through, where I'm going to look at my notes. And are you seeing my notes or just the slides still?
So I just see the slides. I do see the rest of the tabs open. If that's okay with you,
yep, that's fine.
Okay.
Yep. Okay. All right. Thank you. Okay. Hey everybody. Thanks for having me. My name is Ellie Doig. I'm a nurse practitioner at Planned Parenthood of Northern New England. I work at our Manchester clinic. The talk I'm about to give is adapted from one that's usually more like an hour long. So I've really tried to condense it without trying to fit more than I can in 10 to 15 minutes. But I could talk for a really long time on all of this. I have lots of resources for further learning at the end, as well as my email. And I am always happy to have conversations about sexual health and about talking to patients about sex. So please contact me. Also, shout out to my wonderful colleague, Jen Moriarty-Levin, who helped me condense this because I needed help. All right. So I'd like to start with this definition of sexual health from the World Health Organization. So sexual health is a state of physical, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. I know in my training and in a lot of paradigms I've seen used since, there's a lot of focus on kind of the safety around sex. Often in doing that, I think we sometimes neglect some of these other key components. So our wholeness or well-being related to our sex lives, positivity and respect in our sexual relationships and encounters, pleasure in our sexual activity, freedom from violence in those encounters, and also being able to enact a whole host of options around who we partner with, what we practice in our sex lives, how, when, if to parent. So I really like this definition for that. It gets at how sexual health is important to our overall health. It's also really important to our relationships with our patients. So it's really good for our relationships with them when we can talk about sex competently and comprehensively. The sexual health history gives us lots of opportunities. So it's an opportunity for screening. So we've talked a lot about STIs, but we can also talk about, we touched on HPV, cancers. We can screen for violence and intimate partner coercion. It's an opportunity for prevention, also STIs again, but we have the HPV vaccine now. We can talk about prevention of pregnancy if that's important to a patient. It's an opportunity to use harm reduction strategies for prevention, to talk about things like barrier methods, PrEP, contraception. We can do preconception counseling and education for folks thinking about pregnancy. It's also, it brings up sensitive stuff. And if we can do it well, it goes a long way towards developing our relationships with folks that's built on trust, understanding, and mutual respect. So we need to be prepared to have conversations about all of this and more. And I have found in my practice that I needed to be much more prepared than what I learned in nursing school. And so a lot of my education around different types of sexual practices and partnerings came from sources that weren't academic necessarily in nature. And I think it's important to be seeking that out as well. And also patients can kind of tell when we're not prepared for what they're needing. So if I'm a queer patient who's going to my provider and all the language and office stuff is signaling to me that it's pretty hetero focused, that conversation's over before it's even begun. I already know that office or that provider, or I assume that they don't have what I need in terms of understanding my sexual life. I can't talk about sexual health without talking about the frameworks I like to use and really put effort into using. We have to get good about talking about sex, and I think frameworks help me a lot. So, anyone can go through a list of questions to ask a patient to get at sexual health. But my practice uses these frameworks to work at not only how I take a sexual health history, but how I hold space for what that history reveals. So this is how I envision the overlap of frameworks I use. I'm going to speak briefly about each of these. I try to locate myself right in that beautiful overlap in the middle. I think that's when I'm doing my best work. I'm also really working hard at expanding these all the time, introducing new frameworks or changing my understanding of what these are. My current deep work is to try to include an explicitly anti-racist framework in the sexual health that I do, in addition to other aspects of my life. Anyone who has thoughts on that or is interested in the same, I invite you to please be in contact with me. I will also say that it's great when we have these wonderful frameworks to interact with patients with, but it's even better when our institutions have some of these frameworks. So the more we can institutionalize sex positivity, the more we can institutionalize an understanding of trauma and avoiding re-traumatization, the better an experience a patient is going to have with us, and the more accessible we are going to be to a whole host of patients. Okay, so I have a note to myself here, be really brief. I'm just gonna go through each of these real quick. Sex positivity holds that sexuality is a vital component of overall health and well-being, that the sexual spectrum is vast and includes preferences and practices very different from one's own preferences and practices, and that everyone is entitled to competent, comprehensive health education and professional, compassionate, and judgment-free care. The Oxford English Dictionary defines inclusivity as the practice or policy of including people who might otherwise be excluded or marginalized. I think we are all parts of institutions that historically and currently exclude and marginalize folks. That's all I'll say there. There are whole big talks that people can go into about that. Implicit bias is the bias in judgment or behavior that results from subtle cognitive processes, such as implicit attitudes or implicit stereotypes, that often operate within us at a level below conscious awareness and without intentional control. I pair that with values clarification, because values clarification is one process of shining a light on not only our own biases, but also what's important to us, what our values are. Developing awareness around this can help us work to notice when something might be getting in the way or blocking us from seeing and attending to what's important to the patient in front of us. And then trauma-informed care is its whole beautiful own field. The definition I have found and like is that trauma-informed care is a strengths-based framework that is grounded in an understanding of and responsiveness to the impact of trauma, and that emphasizes physical, psychological, and emotional safety for both providers and survivors, and that creates opportunities for survivors to rebuild a sense of control and empowerment. My number one goal whenever I'm taking a sexual health history or exam is not to traumatize or re-traumatize a patient. That is never not on my mind. And it took practice to train myself to think that way. This next slide just kind of gives a little, comparison between kind of a more holistic sex positive approach and that risk-based traditional approach on the right side there. We can kind of see if we operate on that right-sided risk-based framework, we miss a lot of opportunities. I liked what Anne said earlier about like, we got to ask in order to know what we want to, in order to know. We can also see how a patient might experience the sexual history in a kind of a negative way if we're only focusing on these really scary things. That's a small part of what makes them a sexual being, and it's the scary stuff. So I think the challenge in sexual health is to broaden it to understand, what an awesome and amazing thing sex is and how important that can be to our patients. I put this slide up just to illustrate how many ways all the places trauma can come from. Looking at this and thinking about my patient population, a minority of my patients will not have experienced trauma in some form. Right now we are seeing some amazing uprisings across the world in response to centuries of racist trauma. And it's important to note that like we don't get to define trauma for any person or community. It's defined by the person experiencing it. So what might not seem traumatic to me, a routine spec exam or genital swab, could actually be really traumatic for a patient. Or even the way I ask a question, the assumptions I'm making in an interaction. It's also worth familiarizing oneself, and again, there are whole talks and resources on this, but with how trauma responses manifest, specifically in healthcare, that can go a long way to helping us understand behavior that might otherwise, trigger some things in us. In this list, I pay particular attention to medical trauma and system-induced trauma or re-traumatization. So medical institutions can really be sites of trauma and re-traumatization for folks. Right, I'll move on. So the sexual history. When to take a sexual history. I think the first three are pretty obvious. As far as the routine wellness visit, sexual health is definitely part of wellness, so it should be part of our routine wellness assessments. STI visits and contraceptive visits, those bump right up against sexual lives and sexual practices, so it makes a lot of sense there. And I'm not sure how it applies to folks in this audience, but it's worth thinking about how sexual health weaves in with other acute or chronic health conditions. So for example, sexual function or pleasure when someone has, atherosclerotic disease or some other condition affecting their vasculature, or how that interacts with mental health comorbidities and the ability to engage in a pleasurable sexual relationship. So how to do the sexual health history? I like to introduce it, normalize it, ask permission, and invite the patient's agenda. So I introduce it by saying, I'd like to ask you some questions about your sexual health because it's an important part of your overall health. I normalize it. So I ask these questions of all my patients, and everything we talk about is private and confidential. You can include appropriate language there based on, mandated reporting, things like that. I recognize that it might feel awkward or embarrassing to talk about sex with someone you just met. Sometimes that can lighten the mood a little bit, but reassuring folks that I have this conversation all the time with people. I ask permission. Is it okay if we talk about this now? A note on if folks say no in a second, but also important to get the patient's agenda before I dive into my stuff. So I usually just say that, I have a lot of questions I can ask, but before I begin, are there things you want to make sure we cover today? I want to make sure we make room for that. If folks decline, we can ask if there's someone they'd be more comfortable talking about this with, or if there's someone else they'd want present. We can ask if there's a better time to do it. Depending on your rapport with the patient, you could probe a little bit, can you talk to me more about feeling hesitant to talk about that today? In the setting of telehealth, we have to think about privacy. That could be a barrier to take in accurate or comprehensive sexual health histories as well. There are lots of different several different models for, the content of our sexual health history taking. The 5 Ps are from the CDC. I like them. I do think they tend to focus, kind of more on that risk-based paradigm, but I think there are some ways to kind of hack that and open it up for more comprehensive sexual health history taking. Partners. These are some openers. It's small on my screen, but assessing kind of what folks' sexual lives have looked like in the past year and what their partners have looked like, how they identify and how many they've had. In addition to the above openers, we can ask about partners outside of primary relationships. We can screen for intimate partner violence. We can also ask about, sex positivity and satisfaction questions. So how satisfied are you with your sex life? How is sex for you? Is it pleasurable? You having any pain? How's communication go with your partner? What does a good relationship look like to you? To kind of get at what's important to our patients. And again, that might be very different from what's important to us. Practices, this is kind of my favorite stuff to talk about. Just getting at what are folks doing when they have sex. So I think historically there have been questions that we used to stand in for that. So, do you sleep with men or women? Like that actually doesn't tell me very much. What I kind of want to know is like what parts are going where and what are folks using to have sex? And so a lot of times I'll kind of ask it just like that. Or I'll be really direct about it. Are you having penetrative vaginal or anal sex? Are you having receptive oral sex or oral anal sex? Are you performing that? Are there other things you use for sex? Toys, food, stuff like that. And a lot of times, even just starting those questions can be kind of a signal or a door opening for folks who are like, actually, yes, like I'm really into bondage and I have a lot of questions about that, because you've already signaled that you have some awareness of, that practices are expansive and vast. It's a good time to, kind of think about, screening based on behavior. So with, what types of drug paraphernalia might be involved in people's sex lives. So, with intranasal sharing, we think about Hep C, obviously IV drug use. We're thinking about a lot of STI testing beyond just kind of routine gonorrhea and chlamydia stuff. It helps guide, what to test for and what sites to test for, which Anne and Dr. Shu talked about so eloquently. It can guide, asking about practices can guide opportunities for harm reduction and education. It can also help us guide questions to assess, patients' strengths and what their concerns are. And then, often after talking about partners and practices, I'll ask patients, what does me asking these questions bring anything up for you? Or what does this bring up for you? Is this, making you think of anything that you wanted to talk about? And just kind of leave some space for that. Past histories in the CDC model is really, really about getting at kind of histories that put one at risk for STIs. We can also, be asking about IPV. Sometimes here we'll talk about, if I have someone who's expressing concerns about a current relationship, we'll talk about past relationships and like what have been strengths of past relationships, what's worked well, things like that. Can keep moving along here. So protection. I think there are a lot of ways we can get at protection and identify patients' own concerns, strengths, and creativity when it comes to protecting themselves from STIs or from pregnancy. So we can go way beyond the just, are you using condoms or how often are you using condoms? So can you tell me a bit about how you protect yourself from STIs? We can get a lot of, with that, just an open-ended question version of that, we can get a lot of great responses that, help direct the conversation. So, I limit my partners, or we use condoms till we both get tested, or until I feel like I trust them, or we're monogamous, or I'm on PrEP, or I get tested every 3 months, or like, I haven't ever really thought about it and I do want to talk about that. So again, it's just, the more open we are with their questioning, the more opportunity we have to really get patients what they're needing from us. And it kind of broadens that risk model. Pregnancy and parenting. We do a lot of this Planned Parenthood, so I feel like I could talk about this for a really long time. But what I do want to say is that this is a really important place to avoid assumptions based on one's gender identity, the gender identity of someone's partner, who their current sexual partners are, or who they've been in the past, their current parenting status, obviously current, marital status. The example I give here is, I think, teen pregnancy is a real hot issue, and a lot of people are, the knee jerk is like, we need to prevent teen pregnancy, which doesn't leave a lot of room for how to support a teen who comes in and is like, yeah, I do want to be pregnant and I do want to parent. So our job there is to kind of probe and figure out what's important to a patient and how to support them and help them get what they need to succeed in whatever it is that they're wanting to do. Or at least that's how I see my role. Pregnancy and parenting should be applicable across the gender spectrum. everybody has thoughts about how and when and if they want to parent, and we should be assessing for that. The point, and again, I feel like I'm kind of repeating myself here, but the point here is opportunity for education and support, not kind of coming up with a concrete answer for patients necessarily. So, you know, if I have a patient who's like, yeah, I don't want to be pregnant for 12 years, that's not an opening for me to be like, oh, okay, we'll give you a copper IUD that lasts for 12 years. You know, that, that might not be the best option for her based on what's important to her. So instead, what we can do is ask more clarifying questions, such as this list here. So, you know, what have folks been doing to prevent pregnancy? How have those methods felt? What kind of information do you need? What's most important to you about preventing pregnancy? Again, this is all in the realm of people who do want to prevent pregnancy. We can also ask, you know, what do you feel like you need in order to plan for healthy pregnancy for people who are starting to think about becoming pregnant? And we can also explore ambivalence here, you know, so I think this is like, when I was doing my training, there was just like kind of preventing pregnancy or not preventing pregnancy. And I've been really glad to see in the past decade or so, more research happening, like looking into this category of pregnancy ambivalence. So like, no, I'm not actively preventing pregnancy, but I'm not trying either. And kind of what does that mean for a patient? What are they needing in those spaces? I'm including this slide because it's a nice kind of visual flow for the visual folks. It's kind of a useful way to kind of organize based on kind of how folks at the very beginning are talking about what their partnering is looking like. And this one does use kind of, you know, that what I think of as less inclusive, you know, do you have sex with men, women, or both? You know, I could have sex with women, but the women I have sex with have penises. So there's just a big plug here for like asking for what we actually are trying to assess, what parts go where. So beyond the 5 Ps, we can get into more of a sex positivity paradigm here. So asking about pleasure and function and identity, you know, do you have any concerns, or what are your concerns you've had about your sexual function or the sex you're having? Have you had any changes or concerns about your sexual desire or satisfaction or pleasure or partners? Do you have any questions about your sexual orientation, your identity, what you're wanting during sex? And again, we have to be prepared to answer and discuss what comes up with that. So that might require some more research or learning on our part as we go. But I have also found that patients are really generous in teaching me what I need to know when I've shown that I'm open to that teaching. A brief note on sex in the time of COVID. How has it changed? The short answer is it hasn't. People are having sex. People are having sex with new partners. Shout out to Maslow here and his hierarchy of needs. The very bottom there, right next to food, water, breathing, sleeping, is sex. So that's not going away anytime soon. I think those of us working in the field know that. I do think with COVID, you know, we can focus on harm reduction strategies when it comes to reducing the risk of COVID transmission with sex. So talking about limiting partners and periods of monogamy, partnering with people who are already kind of in your circle or in your household. So, you know, with that, people might be having sex with folks they wouldn't otherwise. So, you know, maybe I normally have sex with folks with penises, but I have a cis woman roommate and we're stuck at home together and we're deciding to start having sex together. So it's important to allow for, you know, the way things might be different when we're stranded at home. We can talk about communicating with partners about not just STI risk, but COVID spread and risk. We, you know, for folks who are going to be having sex, we can talk about, you know, sexual positions that limit our face-to-face time, wearing a mask to reduce some of that, you know, kind of panting and sweating. And, you know, could that be fun or kinky for someone? Masturbation, mutual masturbation, phone sex, Zoom sex, whole new world out there. We can also talk about how, you know, COVID has been found in semen and fecal matter. We don't necessarily know what that means for transmission, but, you know, kind of focusing on barriers with oral sex, with rimming, with things like that in order to try to reduce COVID transmission. We also have to think about harm reduction for our folks who make their living via sex and for whom giving up sex is not an option during COVID. And to that matter, also folks who are, you know, being coerced into sex, who are stuck at home with folks coercing them into sex, who can't leave abusive relationships, who are seeing an uptake in IPV and coercion as a result of stay-at-home orders and things like that. Okay, sexual history over telehealth. You know, the biggest thing is like if it's not a good time for the patient, we got to make room some other time and work with them for that. So there are, you know, we'll see patients where privacy concerns might be more intense than when they can come and see us in a clinic. So teens living with their parents, people in a primary relationship who have other relationships, but their primary partner doesn't know that. People with roommates, stuff like that. Good practices to, you know, make sure we are totally focused on the patient, creating a safe space, so no distractions on our end. I have a little kitty snoozing over here that you guys haven't seen this whole time, but she hasn't been distracting me. I've been focused here. You know, using video whenever we can so that patients can see who they're speaking to. And also, yeah, again, being flexible with patients and offering other times or other ways to do the sexual history if that's going to be what works best for them. I'm not going to go over the if you don't have time part because I'm out of time, but happy to answer questions if people have that. Whew, okay, hope I didn't speak too quickly. This is my little thank you slide, my email, and then I have a number of resources slides after this, and y'all will have the slides shared, so hopefully that gets out to you and off we all go. Thanks.
Awesome. Thank you so much, Ellie. Just going through here, I don't see any questions right off the bat. I saw something in the chat box that just said everything was really engaging, so that's great. If there were any other questions for any of the other panelists, you can feel free to put those in now. I'll just kind of wrap before we go back to the questions. We hope you enjoyed everything today and that you learned a lot to bring back with you. Within the next day, or since today's Friday, maybe Monday, you should receive a short survey about the webinar today. And I know how busy everyone is and another survey to fill out, but it really, the feedback helps us kind of manage what we'll do next year. So please, if you could fill that out and send it back, that would be great. Let's see here. I don't see any other questions. Just a lot of good feedback. Thank you, everyone. Thank you, panelists. Thank you, planning committee. And we will see you next year. Everybody stay healthy and have a good weekend.